do that. So I'm Chris Rauscher. I'm a physician in geriatric medicine. My practice, by and large, for most of my career in Vancouver, on the clinical side, has been seeing frail old people at home. So in Vancouver, I drove around the city and visited people at home, and extensively in residential care, and I've had a number of roles in residential care as well, and working relationships with home care, residential care, and mental health. So that's been sort of my work life. And I've also led many of the quality improvement initiatives in British Columbia. Many are structured through primary care, but then they relate to other environments and other people as well. So that's who I am. So just within the theme of just getting us started about thinking about the initiative and the dignity in heart, mind, and action, I put up a definition, but really what it comes down to is that you'll find many definitions. It's one of those concepts where it's really in the eye of the beholder, because it's very values-based. But we wanted to look at the concept of dignity and respect, because it comes from our values-based. And as I said at my intro, I think that's really why we're here, because we actually feel that it's part of our value system. And if you go from dignity, it's really about the culture of caring as well. And the quote there, the past and the present don't have to be the future. And culture change is a process, not a program. So there's a couple of quotes when I was going through and finding the information on that. And there are a number of ways of approaching this, and certainly in residential care, but in hospital, there's a group looking at seniors care in hospital, which will overlap with what we're trying to do here as well. And it's very person-directed through values. And then it actually will lead to a change in organizational practices, physical environments. There's a number of different components for that. And certainly it's a lot about relationships. And there is some evidence, although a lot of it is just sort of case reports and small sort of evaluation type. And I put a couple of links where I found some information. And you can get improvements in quality of life. And a number of different indicators are there, but use of restraints, weight loss, falls, agitation, that's through sort of the care approach. And certainly that's what we're all sensitive to and working on. So although we've sort of streamed it towards medication use and streamed it towards antipsychotics, really we're talking about quality of care in a broad sense. And you know this, so I'm just sort of setting it in context. But there has been some looking at staffing impacts when you actually have a certain type of approach to care. And so reductions in turnover and sick days, increased levels of satisfaction, increased understanding of the culture change and how people can get involved in that, motivation, and just the ability to analyze what's happening in your care environment. So those sorts of things. And I think a lot of you have experience as you start to work through those changes. And on the resident side and family, sort of life engagement, so resident satisfaction and choice in their daily activities, increased engagement, et cetera. So there's a whole variety of different areas that looking at the culture of care has actually had some positive outcomes. Now, I just wanted to put up the relationships, because some people may say, well, why are we looking at antipsychotic medication? Well, from a quality improvement point of view, dignity is so broad, as is culture of care. So it's kind of a way of framing it in something that might be doable, but really we are going to look at broader concepts as well. So you go from dignity to culture of care, and really it's about relationships and meeting needs. And so how do we meet the needs of residents, of families, of the care provider staff in a way that's going to be balanced? And so it's from that needs-based. And certainly one category of that is medication use, and then one class of medications is antipsychotics. So that's kind of a logic link of what we're doing. Internationally, the UK, as in many different things, has really been out front in trying to do this work. And through Christina, we have some links. And now we have some geriatric psychiatrists that have come from the UK. So we have a variety of different links and possibilities. But there they call this a social movement. And in many ways, I think that this is a social movement. We've been around for a long time. And isn't it exciting that we have such a diverse group of people in this room who all want to work together and achieve something? It's not that we haven't been doing things, but I think collectively. So our call to action. In the US, they have a number of partnerships that they've started to prove in improving dementia care in nursing homes, and antipsychotic use is one of their thrusts as well. So we can look to other areas. I personally find that it's really going as locally as possible and supporting the local efforts and the local culture is really where we're really going to be doing our work. But it's good to be knowledgeable about what's going around us. So in relation to antipsychotic medication use, there's been a lot of discussion about, is there a right number and all that kind of thing. But really, it's about a balanced approach, as in anything for medications, particularly the balanced approach. So what's the current state? Well, overall, as an average, the point prevalence is around 35% use. But that's regulars and PRNs, if you actually look at when they've done sort of the aggregate data runs on that. But behind the number, there's a number of considerations. So you really have to look at indications for the medications. And we know that there are chronic psychotic types of conditions where antipsychotics are very effective. And there's some episodic conditions, such as delirium, that might have a psychotic component where they could be used as well. And there is the behavioral and psychological symptoms of dementia, which is sort of the most prevalent type of condition in residential care we might consider for antipsychotics. And there are indications for use in there. So being clear about the indications, but then looking at the practice gaps. And what we found when we've been doing, we have a shared care polypharmacy initiative where we're looking at drug use more widely in the elderly and residential care, just in 8 prototypes currently in the province. And really, our discussions have been around dosages. And certainly our discussion has been around indications, but then our discussion really is around dosages, the use of PRNs, how medications are ordered so that they're not monitored, may not be monitored or reviewed, so they're continued. And that contributes to that 35% figure. And increase and involving the resident and family. So these are some of the themes that we found. I'm sure if you've looked at this more closely, this is what you find as well. So again, it's not purely about the number. It's about taking those considerations in view and working together to figure out what is appropriate with that particular resident in that particular care facility. And then sort of scaling that up. So this is really what we're talking about. So this is a call to action. The Institute of Healthcare Improvement in the US talks about will, ideas, and execution. And we know there's a lot of will. We are a group that have a lot of will to look at this and have already started to look at this. Today, we certainly want your ideas, and we also want to know how you think this can be executed through a call to action and then really engaging a fair number of care facilities and the supports around the care facilities around the province.